Hi students, myself Dr. Ashok, Assistant Professor from the Department of Conservative Dentistry and Endodontics, Vinayamsan Sankaracharya Dental College, Salem. Today what we are going to see about the role of endodontics after dental traumatic injuries. These are the table of contents. Let's talk about introduction. Traumatic injuries of the tooth result in the damage to many dental and periradicular structures, making the management and consequence of the injuries multifactorial. Most commonly it's seen in young patients. Most of the age is 7 to 12 years and mainly due to falls and accidents. Mainly most common region is anterior region of the mouth, affecting the maxillary molar and the mandibular molar teeth, anterior teeth. Then most common type of dental traumas are crown fractures, crown root fractures, luxation injuries and avulsions. Let me talk about the crown fractures. Most crown fractures occurs in young caries-free anterior teeth. This makes maintaining or regaining pulp vitality. Then crown root fractures mostly first treated with periodontally to ensure that there is sufficient and good margin to allow restoration. Then root fractures, in almost every cases the apical segment stays vital, and in many cases the coronal segment of the pulp should be vital or regains vital subsequent to the injury. Then luxation injuries and avulsions are often result in pulp necrosis and also damage to the cemental protective layer of root. Then radiographic examination is important to, according to the IADT recommended 4 different radiographs. First is 90-degree angulation, then 2 vertical angulation, and one is occlusal film radiographs. Then coming to CBCT techniques, CBCT is used to diagnosis the luxation injuries, alveolar fractures, root fractures and root resorption. Then photographic documentation is important for the initial documentation of the injury and for follow-up for examination. Then photographic documentations allow monitoring of soft tissue healing, assessment of tooth discoloration, re-eruption of intruded tooth and development of infrapositioning of ankylosed tooth. Then there are 2 types of pulp vitalitors. One is cold test and electric pulp test used to determine the condition of pulp. The temporary loss of sensibility is frequent finding during post-traumatic pulp healing, especially after luxation injuries. The lack of response to the pulp sensibility testing is not conclusive for pulp necrosis in traumatized tooth. So pulp sensibility test should be performed initially and at the each follow-up appointment in order to determine if changes occurs in any time. Then follow-up after dental trauma. Follow-up is very important. The initial examination, then 2 to 4 weeks later, then 6 to 8 weeks later, and 3 to 6 months later. Then teeth that gives a response at the initial examination cannot be assumed to be healthy and to continue to give a response over time. Then teeth with yield no response cannot be assumed to have necrotic pulp because they may give a response at later follow-up visit. It has been recommended that it may take up to 9 months for blood flow to return to normally in fully formed traumatized tooth. As a result, follow-up visits are necessary to monitor the pulp response and ensure the proper healing. Then CO2 spray at minus 78 degrees Celsius, 40 degrees Celsius placed on the facial surface of the incisal third seems to provide more accurate response to intense cold than water ice pencil. Then laser Doppler flowmetry is used to diagnose the pulp vitality in traumatized tooth. This would provide a more accurate reading of the vitality status of the pulp, indicating the laser Doppler can detect blood flow more consistently and earlier than the standard vitality test would be expected to return the response in it is more cost effective. Then coming to the enamel infraction. Enamel infraction means incomplete fracture of the enamel without loss of tooth structure. Mostly the pulp sensibility test usually positive response. Treatment protocol is, in case of severe infraction, etching and sealing with bonding resin should be considered to prevent discoloration and bacterial contamination of the infraction. So otherwise no treatment is necessary. Coming to uncomplicated crown fractures means fracture of the enamel only or the enamel and dentin without involving the pulp, and most commonly reported dental injury. The treatment protocol is first sealing the exposed dentinal tubules. If the tooth fragment is available and intact, it can be bonded back on the tooth. The fragment should be rehydrated by soaking in water or saline for 20 minutes before bonding. Cover the exposed dentin with glass cyanomer or use of bonding agent and composite resin. Then applying a composite band-aid or temporary coverage can effectively protect the exposed dentin. If the exposed dentin is within 0.5 mm of the pulp, place a calcium hydroxide lining, cover the tooth surface with the glass ionomer. See in this picture you can see the band-aid composite that are applied over the fractured tooth. So after if any soft tissue injury is there, we have to take radiograph to confirm any foreign bodies should be present or not. Coming to the complicated crown fracture means it involves mainly on enamel, dentin and pulpal region. So it occurs 0.93% to 13% of all dental injuries. A treatment protocol should follow the mostly vital pulp therapy according to pulp capping, partial pulpotomy or full pulpotomy or pulpectomy. The choice of treatment depends on the stage of development of the tooth, the time between the trauma and treatment, concomitant periodontal injury and restorative treatment plan. Then requirement for success of vital pulp therapy should be treatment on non-inflamed pulp. The treatment of healthy pulp has shown to the important requirement for successful therapy. Bacterial tight seal is very important. Then pulp dressing, calcium hydroxide has been used. It is a main advantage. It's an antibacterial and disinfect the superficial pulp. Then calcium hydroxide is a high pH, 12.5 pH, causes the liquefaction necrosis in the most superficial layers. Then pulp capping agents, MTA and bioceramic materials are available. MTA has prolonged setting time and discoloration of the crown because of the bismuth oxide filler in the material. New generation bioceramic materials sets quickly enough for one visit procedure and do not discolor the tooth. Currently, bioceramic materials are considered the pulp capping agents of the choice. Then pulp capping treatment protocol implies placing the dressing directly on the pulp exposure without removal of soft tissues. The success rate of this procedure is 80% compared with the partial pulpectomy, 95%. Indicates that superficial pulp could not be considered after traumatic pulp exposures. A bacterial tight coronal seal is much more difficult to attain in superficial pulp capping because there is no depth to the cavity to aid in creating the seal. Then let me talk about the partial pulpotomy. It's also known as Shivak pulpotomy. The prognosis is extremely good. 94% to 96% success rate is that the patient present for the treatment within 48 hours. Then the treatment protocol is the fractured teeth are cleaned and disinfected. Cavities are prepared at a high speed with a round diamond burr. The end tip is 1 to 2 mm into the pulpal tissues. If a bleeding is excessive, the pulp is amputated deeper until only moderate hemorrhage is seen. The use of 5% sodium hypochlorite has been recommended to rinse the pulpal wound. Then calcium hydroxide on plugger is placed on the soft tissue of the pulp. Then cavity preparation are filled with the glass ionomer cement. The exposed dentin is etched and then covered with composite resin. Radiograph 6 months later shows a formation of hard tissue barrier in both the teeth. Alternatively, after hemostasis has been obtained, the pulp can capped with MTA covered with the lining material and then restored with composite restoration. Then coming to full pulpotomy is indicated when the traumatic exposure after more than 72 hours and carries exposure of young teeth with the developed apex. Then disadvantages is sensitivity testing is not possible because of the loss of coronal pulp. So radiograph follow-up is extremely important to assess the signs of apical periodontitis and to ensure the continuation of root formation. The prognosis is 75% success rate is compared to partial pulpotomy because the inability of to evaluate the pulp status after pulpectomy. Coming to pulpectomy, the means removal of entire pulp to the level of apical peramen. Then it indications mostly complicated crown fracture of the mature teeth. If conditions are not ideal for the vital pulp therapy, then this procedure is no different from the root canal treatment of vital non-traumatized teeth. The pulpectomy procedures having a success rate of 95%. If apical periodontitis develops, the prognosis of the root canal treatment drops approximately 80%. Then if immature tooth, what will do? Apexification we have to do. Then the techniques of apexification is first disinfect the root canal system to ensure periapical healing. The increased volume of irrigant used compensates for this lower concentration of sodium hypochlorite with the use of 0.5%. Then canal is dried with a paper point and a creamy mix of calcium hydroxide spun into the canal with the help of lentinospiral instruments. In these pictures you can see the lentinospiral is attached in the micromotor handpiece. Then additionally, disinfecting with calcium hydroxide is effective after its application for at least 1 week. We have to keep inside the canal. Then calcium hydroxide is packed against the apical soft tissue to initiate the hard tissue formation. This step is followed by backfilling with the calcium hydroxide to completely fill the canal. The radiograph is taken and the canal should appears to have become calcified and indicating the entire canal has been filled with the calcium hydroxide. The 3 months interval radiograph is exposed to evaluate whether the hard tissue barrier has formed and if the calcium hydroxide has washed out of the canal. If no washout is evident, the calcium hydroxide can be left intact for another 3 months. When complication of hard tissue barrier is suspected, calcium hydroxide should be washed out of the canal with hypochlorite. A file of size that can easily reach the apex can used to gently probe for a stop at the apex. And the hard tissue barrier is indicated radiographically and can be probed with an instrument and the canal is ready for filling. Then the creation of physiological hard tissue barrier takes anywhere from 3 to 18 months with the calcium hydroxide. The disadvantage is it's for long time period of the patient is required to present for the treatment of multiple visit and the tooth may fracture during the treatment before the thin weak root can strengthen. Recent studies showed that calcium hydroxide did not weaken the teeth over the time. Fracture may more related to the stage of root development rather than the calcium hydroxide use. Then coming to the bioceramic barrier. Bioceramic material used to create the hard tissue barrier quickly after the disinfection of the canal. Calcium sulfate is pushed through the apex to provide the resolvable extraradicular barrier against which to pack the bioceramic material. First the material is packed and then mixed and then packed into the apical 4 to 5 mm of the canal. A wet cotton pellet was placed against the bioceramic material and left for at least 6 hours. The canal is filled with thermoplasticized gutta percha. Then the cervical canal is then reinforced with the composite resin to allow to below the marginal bone level. Then filling the root canal. If the hard tissue barrier was produced by the long-term calcium hydroxide therapy, it consists of irregularly arranged layer of coagulated soft tissue, calcified tissue and cementum-like tissues. It includes also islands of soft connective tissues, giving the barrier a swish pattern consistency. Filling should be completed to the level of hard tissue barrier and not forced towards the radiographic apex. In this histological appearance showing the hard tissue barrier formation. Then moving to the reinforcement of thin dentinal wall. Secondary injuries occurs. The teeth with the thin dentinal walls are more susceptible to fractures that render them the unrestorable. Studies have shown that the intracoronal bonded restoration can internally strengthen endodontically treated teeth and increase the resistance to fractures. After root filling, the material should be removed to below the marginal bone level and bonded restoration filling should be placed. Then pulp revascularization or regeneration endodontic treatment. The immature permanent tooth. There are 3 outcome measures for the success of pulp revascularization. The primary goal is to elimination of symptoms and evidence of bony healing. Secondary goal is increased root wall thickness and or increased root length, which is considered desirable but perhaps not essential. The tertiary goal should be positive response to pulp vitality testing. Regeneration of necrotic pulp possible only after avulsion of immature permanent tooth that was reimplanted within 40 minutes. The reimplantation of avulsed immature teeth which allows new tissue to grow into the pulp space quickly. It has been experimentally shown that the apical part of the pulp may remain vital and after reimplantation proliferate coronally and replacing the necrotized portion of the pulp. The advantages of revascularization is the root development and the reinforcement of dentinal wall by deposition of the hard tissue, the strengthening the root against the fracture. The disinfection of the canal involved no mechanical preparation but copious irrigation with the help of hypochlorite was performed, followed by the calcium hydroxide can be used as an intracanal medicament. Then biodentin when used as an intracanal barrier result in less crown discoloration compared to the MTA. These are the article from the Australian Endodontic Journal. Andrea et al. Concluded that the complete healing with apexification and regenerative endodontic procedures were 86% and 95% success rate. Then apexification and regenerative endodontic procedures provide satisfactory outcomes concerning clinical success rate. Continued root development in regenerative endodontic procedure was similar to apexification except for root width. Then moving on to next heading, uncomplicated crown root fractures called as crown root fracture without pulp exposure. So mostly fracture involving enamel, dentine and cementum. The treatment protocol is based on until a treatment plan is finalized, the temporary stabilization of the loose fragment to the adjacent teeth or tooth or the non-mobile fragment should be attempted. If the pulp is not exposed, the removal of the coronal or mobile fragment and the subsequent restoration should be considered. Cover the exposed dentine with the glass ionomer or use of bonding agent and composite resin. Then fracture involving the enamel, dentine, cementum and pulp is called as complicated crown root fracture. There are treatment protocols should be immature teeth with the incomplete root formation, mainly on advantages to preserve the pulp by performing a partial pulpotomy. Then placing a non-setting calcium hydroxide or non-staining calcium silicate cement or suitable material to place on the pulpal wound. Then in treatment protocol for mature teeth with the complete root formation is removal of pulp is usually indicated. Cover the exposed dentine with the glass ionomer or use of bonding agent and composite resin. Then moving on to the next topic is root fracture. The fracture of the root involving dentine, pulp and cementum. The fracture may be horizontal, oblique or combination of both. In this picture is showing the fracture line first present in the supracrustal coronal third of root fracture, then second line shows the subcrustal coronal third root fractures, then third line shows the middle third root fracture, for that at the end is apical third of root fractures. The treatment protocol is if displaced the coronal fragment should be repositioned as soon as possible. Check repositioning radiographically. Stabilize the coronal segment with a passive and flexible splint for 4 weeks. If the fracture is located cervically, stabilize for a longer period of time up to 4 months may be needed. The coronal fragment, especially if not mobile, should not be removed at emergency visit. No endodontic treatment should be started at the emergency visit. It is advisable to monitor healing of the fracture for at least 1 year. Then pulpal status should be also monitored. Then apical segment rarely undergoes pathological changes that requires treatment of root canal treatment. Then healing patterns, there are 4 types of response to the root fractures. One is healing with calcified tissue. Is radiographically the fracture line is discernible but the fragments are in close contact. Then second one is healing with interproximal connective tissue. Radiographically the fragment appears separated by narrow radiolucent line and then fractured edges appear rounded. Then third one is healing with interproximal bone and connective tissue. Radiographically the fragments are separated by distinct bony ridges. Then fourth one is interproximal inflammatory tissue without healing. Radiographically a widening of fracture line or developing radiolucency corresponding to the fracture line becomes apparent. The first 3 healing patterns are considered to be successful. Then treatment complications of coronal root fracture, mainly in mature teeth where the cervical fracture line is located above the airlock crest. In this picture you can see the fracture line. The coronal segment is, the cervical fracture line is located above the airlock crest and the coronal fragment is very mobile, and removal of the coronal fragment followed by the root canal treatment and restoration with the post retained crown will be required. The level of fracture and the length of remaining root are evaluated for responsibility. If the apical root segment is long enough, gentle orthodontic eruption of this segment can be carried to enable fabrication of the restoration. Then mid-root and apical root fractures in mature teeth, the permanent pulp necrosis occurs in 25% of root fractures. In most cases, permanent necrosis occurs in the coronal segment with only the apical segment remaining vital. Therefore, endodontic treatment is indicated in the coronal root segment unless periapical radiolucency is seen in the apical segment. The coronal segment is filled after a hard tissue barrier has formed apically in the coronal segment and periradicular healing has taken place. In rare cases in which both coronal and apical pulp are necrotic and treatment are more complicated, endodontic treatment through the fracture is extremely difficult. Then endodontic manipulation and medicament and filling materials all have a determinal effect on healing of the fracture site. In more apical root fractures, necrotic apical segment can be surgically removed. This is a viable treatment if the remaining coronal root segment is long enough to provide adequate periodontal support. Then follow-up should be 3 to 12 months and yearly. Then at least for 5 years follow-up is mandatory. Then prognosis is based on the quality of treatment is vital to successful repair. Then prognosis improves with quick treatment, close reduction of the root segment, semi-rigid splinting should be used at least for 2 to 4 weeks. Then complication is mostly on pulp necrosis and root canal obliteration. Then alar fractures. The fracture involves the alar bone and may extend to the adjacent bones. The clinical findings are alar fracture is complete and extend all the way from the buccal to the palatal bone in the maxilla and from the buccal to the lingual bony surface in mandible. Segment mobility and displacement with several teeth moving together are common findings. The teeth in the fracture segment may not respond to the pulp sensibility testing. Reposition any displaced segment first, then stabilize the segment by splinting the teeth with passive and flexible splint for at least 4 weeks. Root canal treatment is contraindicated for in emergency visit. Monitor the pulp condition of all teeth involved both initially and at follow-up to determine if or when endodontic treatment becomes necessary. Then moving on to luxation injuries, first is concussion, implies on no displacement, then normal mobility and sensitivity to percussion. The treatment is based on the injuries, by basically no treatment is indicated for concussion. Then subluxation, an injury to tooth supporting structures with abnormal loosening but without displacement of the teeth. The treatment based on the normally no treatment is needed if passive and flexible splint the teeth for up to 2 weeks may be used, but only if there is excessive mobility or tenderness when biting on the teeth. Then excessive luxation, displacement of the teeth out of its socket and is an incisal or axial direction. A treatment based on repositioning the teeth by gently pushing it back into the tooth socket under the local anesthesia. Stabilize the tooth for 2 weeks using a passive and flexible splint. If breakdown or fracture of the marginal bone, splint for additional 4 weeks. Then monitor the pulp condition with pulp sensibility test. If the pulp becomes necrotic and infected, endodontic treatment appropriate to the tooth stage of the root development is indicated. Lateral luxation means displacement of the tooth in any lateral direction, usually associated with the fracture or compression of the alar socket wall or facial cortical bone. Treatment protocol is reposition the tooth digitally by disengaging it from locked position and gently reposition into its original location under local anesthesia. Then methods to first method is palpate the gingiva to feel the apex of the tooth, then use one finger to push downward over the apical end of the tooth, then use another finger or thumb to push the tooth back into the socket. Then stabilize the tooth for 4 weeks using passive and flexible splint. If breakdown or fracture of the marginal bone or alar socket wall, additional splinting should be required. Then teeth with incomplete root formation, the main thing is focused on spontaneous revascularization may occur. If the pulp becomes necrotic and there is a sign of inflammatory external root resorption, the root canal should be started as soon as possible. The teeth with the complete root formation, the pulp will become necrotic. Root canal treatment should be started using a corticosteroid antibiotic paste or calcium hydroxide as an intracanal medicament to prevent the development of inflammatory external resorption. Then this is the article from the Dental Traumatology 2024. Tiwari et al. Concluded that the prevalence of pulp necrosis was found to 57% and it was 12% in immature teeth and 58% in mature teeth. Then There are greater chances of pulp necrosis in teeth with the later luxation, especially with mature apex. Less than 60% in most cases, the prevalence of external inflammatory root resorption, less than 20%. So, absolute recommendation for endodontic intervention in immature teeth with lateral luxation is indicated. The moving on to intrusive luxation means displacement of teeth with apical direction into the alar bone. The teeth with incomplete root formation. The treatment protocol is allow re-eruption without intervention for all intruded teeth independent of the degree of intrusion. If no re-eruption within 4 weeks, initiate the orthodontic repositioning. Teeth with complete root formation in mature teeth. Allow re-eruption without intervention if the tooth is intruded in less than 3 mm. If no re-eruption within 8 weeks, reposition surgically and splint for 4 weeks with passive and flexible splint. Alternatively, the reposition of orthodontically before ankylosis develops. If the tooth is intruded 3 to 7 mm, reposition surgically or orthodontically. If the tooth is intruded beyond the 7 mm, reposition surgically. This is an article from the Australian Dentistry 2016. Abbott et al. Conclude that the use of corticosteroid antibiotic intracranial medicament has been shown to particularly useful in prevention and management of external inflammatory root resorption. Calcium hydroxide should not be used as an immediate medicament because of its toxicity and irritant properties as a valuable as a subsequent medicament to encourage a hard tissue repair when required. This is an article from Clinical Oral Investigating 2020. Souza et al. Conclude that the highest incidence of root resorption was observed for the teeth of intrusive luxation, followed by those of extrusive luxation, lateral luxation, subluxation, then concussion. In general, the most common type of root resorption documented for all injury was inflammatory root resorption, followed by the replacement root resorption, then surface root resorption and internal root resorption. Then management of owl's tooth. Tooth avulsion results in attachment damage and pulp necrosis. If the periodontal ligament left attached to the root surface does not dry out, the consequence of the tooth avulsions are usually minimal. Because the area of crushing injuries are localized, inflammation stimulated by damaged tissues will be correspondingly limited and favorable healing with the new replacement cementum. If excessive drying occurs before replantation, the damaged periodontal ligamental cells elicit a severe inflammatory response over a diffuse area on the root surface. Slower moving cementoblast cannot cover the entire root surface in time, and bone will attach directly onto the root surface and the entire root will be replaced by bone termed as replacement resorption. If revascularization does not occur or effective endodontic therapy is not carried out, the pulp space inevitably becomes infected. So the result is external inflammatory resorption will occur and rapid loss of tooth root. Clinical management of owl's tooth emergency treatment at the accidental site. Replant if possible or place in an appropriate storage medium. Of utmost importance is prevention of drying, which causes loss of normal physiological metabolism and morphology of periodontal ligamental cells. Replant the teeth within the first 15 to 20 minutes immediately. Then storage media for owl's tooth suggested the milk and saliva of the vestibule of the mouth or in the container in which the patient physiological saline or water. The water is the least storage medium because the hypotonic environment causes rapid cell lysis and increased inflammation on replantation. So mostly HBSS have been superior ability to maintain the pulp vitality of the posterior ligament fibers for extended periods. Then management of owl's teeth in dental office. First, emergency visit, prepare the socket, prepare root, replant, construct a functional splint. Then preparation of the socket should be left undisturbed before replantation. Then preparation of the root. The preparation of the root depends on the maturity of the tooth and on the dry time of the tooth before it was placed in the storage medium. The dry time of 60 minutes is considered the point where the survival of root periodontal ligamental cells. Then external dry time less than 60 minutes is the first visit for closed apex. The root should be rinsed off debris with water or saline and replanted in as gentle. The dry time is of less than 15 to 20 minutes considered as optimal and periodontal healing would be expected. The teeth that has been dry for more than 20 minutes but less than 60 minutes. In these cases, the the root surface consists of some cells with the potential to regenerate and some that will act as inflammatory stimulators. In case of open apex, the gentle rinse of debris, soak in doxycycline for 5 minutes or cover with minocycline and then replant the tooth. In open apex tooth, revascularization of the pulp and continued root development are possible. Soaking the tooth in doxycycline 1 mg approximately 20 ml of physiological saline for 5 minutes before replantation significantly enhanced the complete revascularization. Then extraoral dry time more than 60 minutes in owl's tooth for closed apex. When the root has been dry for 60 minutes or more than 60 minutes, the survival of periodontal ligament cell is not expected. These teeth should be soaked in acid for 5 minutes to remove all remaining periodontal ligament cells. The teeth can be soaked in 2% stannous fluoride for 5 minutes and then replanted. If the tooth has been dry for more than 60 minutes and no consideration is given to preserving the periodontal ligament cells, and the endodontic may be performed extraorally. In open apex cases, the endodontic treatment performed after replantation involves a long-term apexification procedure. In their cases, completing the root canal treatment extraorally, in which a seal in blunderbuss apex is easier to achieve, may be advantageous. When endodontic treatment is performed extraorally, it must be performed aseptically with the utmost care to achieve root canal system that is thoroughly disinfected. Then coming to splinting methods, flexible fixation for 1 to 2 weeks is recommended. Composite and wire splint, the wire diameter is no greater than 0.4 mm is considered to be flexible splint. In this picture is a titanium trauma splint shown to particularly effective and easy to use. The only expectation in with the avulsion in conjunction with the alveolar fractures for 4 to 8 weeks is suggested for splinting time. Then adjunctive therapy is symptomatic antibiotics should be taken at the time of replantation and before an endodontic treatment are effective in preventing the bacterial invasion of necrotic pulp and therefore subsequent inflammatory resorptions. And patients should be sent to physician for consultation regarding the tetanus booster vaccine within 48 hours of initial visit. Then coming to management of owl's tooth in second visit, it's an endodontic treatment protocol based on the extraoral time less than 60 minutes. Closed apex, endodontic treatment should be initiated at the second visit 7 to 10 days later. When the endodontic treatment is delayed or sign of resorption are present, provide long-term calcium hydroxide before obturation. The long-term calcium hydroxide treatment should always be considered if injury occurred more than 2 weeks. Before initiation of endodontic treatment or especially if radiographic evidence of inflammatory resorption is present. The antibiotic corticosteroid paste called as Ladermex is effective in treating inflammatory root resorption by inhibiting the spread of dentinoclast without damaging the periodontal ligament cells. In open apex cases, avoid endodontic treatment and look for sign of revascularization. The external inflammatory root resorption can be extremely rapid in these young teeth because the dental tubules are wide and allow irritants to move freely to the external surface of the root. The patient should be recalled every 3 to 4 weeks for pulp vitality testing and radiographically signs apical breakdown or sign of later root resorption, and clinical signs mostly pain and percussion and palpation of pulpal pathosis are carefully assessed. At the first sign of pulpal pathosis, the endodontic treatment should be initiated, and after disinfection of the root canal space, the apexification procedure should be carried out. In second visit of endodontic treatment protocol, extraoral dry time more than 60 minutes. In closed apex, teeth with closed apex are treated endodontically in the same way as teeth had extraoral time of less than 60 minutes. In open apex cases, if endodontic treatment was not performed out of the mouth, initiate the apexification procedure, then the chance of revascularization in the teeth is extremely poor, so no attempt is made to revitalize them. Then temporary restoration for owl's tooth. Effectively sealing the coronal access is essential to prevent the infection of canal between the visits. Recommended temporary restorations are reinforced zinc oxide eugenol cement acid etch, composite resin or glass ionomer cement. The depth of at least 4 mm is recommended. So cotton pellet should not be placed. The temporary restoration is placed directly onto the calcium hydroxide in the access cavity. Then root filling for owl's teeth. If the endodontic treatment was initiated 1 to 2 weeks after the avulsion and thorough examination confirms normality, filling of root canal at the visit is acceptable. Traditionally, the re-establishment of lamina dura is a radiographic sign that the canal bacteria has been controlled. When intact lamina dura can be traced throughout and root filling can be taken place. The follow-up care is mostly should take place at 3 months, 6 months and yearly for at least 5 years. Then this is an article from Dental Traumatology 2024. Gull et al. Conclude that the 17% of risk of ankylosis for immediately replanted teeth, 55% for stored in physiological medium before replantation, 85% as chance for teeth stored in dry more than 1 hour. Then finally, the mature teeth showed a significantly higher risk of ankylosis than compared to the immature teeth. This is the quick summary of this class. Dental trauma is a biological injury, not just a fracture. Pulp, periodontal ligament, cementum and bone are involved. Correct diagnosis at the first visit, clinical, radiographic and sensibility test determines the long-term prognosis. Negative pulp sensibility immediately after trauma is compared to the pulp necrosis. Repeated follow-up is compulsory. Then preservation of pulp vitality is the primary goal, especially in the immature permanent teeth. Then partial pulpotomy has the highest success rate among the vital pulp therapy. The time factor is a critical in early treatment. Early treatment improves the healing and success survival of the tooth. If non-vital immature teeth, bioceramic apical barrier reduce the treatment time and risk of root fractures. Regenerative endodontics offers the advantage of continued root development and thin dentinal thickening of dentinal wall. Then flexible splinting should be used, not rigid fixation. Promotes the periodontal healing in luxation and avulsion injuries. Then avulsion is a true dental emergency. The PDL cell's survival depends on the extra oral dry time and storage medium. And complications such as root resorption and ankylosis are more common in dental traumatic injuries, and the long-term follow-up should be mainly indicated. Yearly diagnosis, preservation of pulp vitality and meticulous follow-up are the cornerstone of successful endodontic management of the dental trauma. Thank you for watching my class.